And then, most importantly, we have a very special conference this weekend on adult congenital heart disease. We're going to have a great series of panel discussions based around specific cases that we face on a daily basis in adult congenital heart disease. So I welcome all of you to attend. And of course, we'll be featuring Dr. Alshawabkeh. And then, of course, finally, very exciting, we'll be having the 13th annual Pumps and Pipes on November 11th. So at this point, I'm really thrilled to introduce our speaker today, Dr. Laith Alshawabkeh. Went to medical school at University of Cairo. He did his internal medicine residency at UT Southwestern and went on to do his fellowship in cardiology at University of Iowa, and then did his fellowship in adult congenital heart disease at the Boston Adult Congenital Heart Program. So many people think that I've done a pretty good job at building an adult congenital heart program, but I pale in comparison to Dr. Alshawabkeh, who built his program in 2 years. Within 2 years, he now has a panel of more than 100 single ventricle patients, and now is rapidly becoming one of the top programs in the world as far as single ventricle transplant. And so I can find no speaker that's better qualified to talk about the approach to heart failure in adult with congenital heart disease. We've moved the Overton window. Laith?
Wow, thank you so much, Huie, for a very, I think my mom would be very proud. So thank you so much for having me here today. It's good to be back in Texas. And if you could bear with me for the next hour, I'll be talking to you about a topic that is very dear to my heart, as it is arguably the final common pathway to a lot of adults with congenital heart disease. So we'll start with some historical perspective. And back to the 1930s with the first successful surgery to treat a congenital heart disease defect, where Dr. Robert Gross at the Boston Children's Hospital, at the time he was a chief surgical resident under William Ladd. Many of us know the Ladd procedure for the malrotation of the gut. And at the time, Dr. Gross had a research lab where he was trying to operate on various types of defects. And he was always trying to basically apply it to bedside. And basically, always Dr. Ladd told him, you can never do this. So what does he do? He waits until Dr. Ladd is out on vacation. And he calls one of his patients, and he operates, and then he gets fired for 3 months. But he was kind of magically reinstituted after 3 months of him going back to his, he had a farm in Massachusetts. But that basically ushered the door towards kind of intrathoracic surgery. This wasn't really intracardiac repair at the time. And for that, you have to think about the different types of innovations that came through. But that patient, her name is Lorraine Sweeney, was featured recently, I believe in NPR at the age of 80 with her great-grandkids. So that was a phenomenal, really, feat for that age. But, we're here, and we have to acknowledge the contributions of Dr. DeBakey, and I can think of 2 major contributions that directly impacted congenital heart disease surgeries. One is the Dacron vascular grafts, which we still use to this day. And also, he invented the roller pump, which is an early form that basically motivated the development of the cardiopulmonary bypass machine, and obviously allowed intracardiac repair to be performed. And if you take a 30,000 view at the history of congenital heart disease care, up to that time, it was really a description of pathology and very beautiful drawings in textbooks about the pathology of congenital heart disease. But true palliation didn't start until the 40s and 50s. And then in the 60s to 80s, people started doing childhood intracardiac repair. And what's been recently vogue is the neonatal repair, where patients get their definitive surgery before they leave the hospital. And all of these have basically catapulted these patients into adulthood and allowed someone like me and Huie to talk to you about this specialty in Valeria as well. So the scene now in the United States is interesting. On the left-hand bars is the year 2000, and then compare that to the year 2010. In red are the adults, and you notice that's been a 57% increase in the prevalence of adults living with congenital heart disease just within a 10-year period. Whereas for children, the increase has been 11%, which is obviously reflective of increased awareness and detection, but also just the growth of the population. So obviously, our adults are becoming more and more prevalent, and this also applies for those with severe forms of congenital heart disease. So in fact, now the number of adults living with congenital heart disease has overtaken the number of kids living with congenital heart disease in the US. And there are currently approximately 2 million adults with congenital heart disease living in the US. So let that sink in a little bit, because I think that's even a little bit more than the number of people with atrial fibrillation or chronic AFib. And many of us consider AFib as a cornerstone of training in general cardiology. So ACHD now is considered basically a cornerstone of general cardiology training, and indeed that's what we're doing in San Diego. I'd like to start with 3 case presentations before we talk specifically about the heart failure. I will start with Michael. So Michael is a 29-year-old patient who was born with tricuspid and pulmonary atresia with hypoplastic right ventricle and an unrestricted atrial septal defect. And he underwent a palliation with a lateral tunnel Fontan. So for the non-congenital crowd in the audience, basically a Fontan circulation is where you connect the inferior vena cava and the superior vena cava directly to the pulmonary artery. And the idea is to preserve that single ventricle for pumping to the systemic circulation. So conceptually, I know my colleagues may not like this, but that's how I think about a Fontan circulation when I'm talking to someone who's not a congenital specialist. Just think of the heart as a pumping chamber that is delivering red blood to the aorta, and the systemic veins have been rerouted directly to the lung to their ultimate destination, which is, the lungs to get oxygen. So that's conceptually how a Fontan circulation works. So he presented to an outside hospital with syncope. Unfortunately, just like many of our ACHD patients, he was lost to care for years. And he was found to have incessant ventricular tachycardia and arrested in the ER. They miraculously resuscitated him, and they transferred him to our center for further evaluation. So we obtained an echo and ultimately an MRI. So this was his MRI. And you don't need to be an imager to recognize that there is severe systemic ventricular dysfunction happening here. So what about the plumbing? Is the plumbing okay? The answer is yes. So we do these 4D flow MRIs that give us a great idea about the gradients, multiple shunts, and also gives us gradients in obstruction in series. And this is his Fontan conduit. It's widely patent, and his pathway to the aorta is patent, and there is no significant atrioventricular valve regurgitation. So essentially, this is a pure cardiomyopathy. So in summary, he had tricuspid atresia, unobstructed Fontan circuit, severe cardiomyopathy, but he had a resuscitated sudden cardiac death due to VT. Case number 2 is Nick, who was 40 years old, born with D-loop transposition of the great arteries, which was palliated via the mustard atrial switch operation. And he's had 8 admissions with acute decompensated heart failure over the past year. So transposition or D-loop transposition is where the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. This is a cyanotic form of congenital heart disease. It's nearly incompatible with life. So these patients have to have surgery before they're discharged from the hospital. Way back when, he's 40 years old, so up to the late 80s, all babies born with transposition underwent the atrial switch operation. Back when people did not know, or it wasn't very prevalent to switch the arteries, which is what we do now. and instead they switch the atria. So think of it as, negative and a negative equals positive. Ultimately, the blue blood will end up in the lungs and the red blood will end up in the aorta, but the pumping chamber that you're using to achieve this in this anatomy is the right ventricle, is now the systemic ventricle. So he had multiple issues also with his plumbing. He had SVC limb baffle stenosis, and he underwent stenting. He had dual chamber pacemaker, and you can imagine if you put all these suture lines in the atria that a lot of these patients develop sinus node dysfunction. He had also little kind of issues here and there. He had left upper pulmonary vein, was a little bit atretic, but essentially most of his pulmonary venous return was unobstructed. And he has some other comorbidities that he remarkably has overcome over the years, namely the morbid obesity. And this is his presenting echocardiogram. So I tried to not do it the congenital format, and this is flipped, the usual adult format. So this is still the right ventricle, but remember, this is the systemic ventricle. And what you see compared to the left ventricle, which is robust, is the function of that right ventricle is probably at least moderately reduced, and there is moderate tricuspid regurgitation. So that's physiologically, think of it as analogous to mitral regurgitation. So Nick is a D-loop TGA, status post-mustard, failing systemic right ventricle, and he has recurrent admissions with acute decompensated heart failure. The third and last patient is Geoff. So I'm going to summarize what's on the slide here. This is a 26-year-old patient, was born with tricuspid atresia and had multiple other issues. Ultimately, he was palliated to an extracardiac Fontan. So think of him as a single ventricle status post Fontan. He had reduced ventricular function, and he does have a residual shunt that is overloading his ventricle. He had a very unusual form of Fontan where they left a communication between the hypoplastic right ventricle and the pulmonary arteries. He is chronically ventricularly paced because his atrial lead failed. And he has advanced and bridging fibrosis of the liver. And this is his echocardiogram, where you see the systemic ventricle. In this case, it's a morphologic left ventricle, is moderately reduced in function, and there is mild to moderate mitral regurgitation. And you see here slightly the hypoplastic right ventricle in view, and the large inner atrial communication is patent. So in summary, Geoff was born with a single ventricle physiology, palliated to a Fontan, and now has failing Fontan circulation and a severely reduced LVEF with the added issue of advanced liver fibrosis. So we'll kind of detach a little bit from these cases and just talk about heart failure, and we'll come back to these cases and what we've done for these patients. I would like to start with the question is, how do you identify those with advanced heart failure among patients with congenital heart disease? To that, you have to think, okay, what is the definition of heart failure in adults with congenital heart disease? You can't really apply the usual heart failure definition because, a lot of these patients were born with some sort of heart failure. And they carry this for the rest of their lives. So, you can see here multiple authors try to pin down the definition of heart failure in congenital heart disease, and these are very variable and heterogeneous definitions. It's just a reflection of the heterogeneity of this population. But if you go a step back and think about the pathophysiology, or the underlying pathophysiology of heart failure in these patients, think of cyanosis as a cause for effort intolerance, like those with Eisenmenger syndrome, residual shunting. You think of abnormal kind of communications or connections. There is narrowings in the baffles and so forth. Think of the Fontan circulation, that sometimes it's a multi-system disease where the liver fails and also the lungs fail, and patients have hypoalbuminemia and have effusions. We also think of other issues such as incessant atrial arrhythmias. Sometimes, some patients had transection of the coronary arteries at the time of surgical repairs due to anomalous course of these arteries, and they carry heart failure for the rest of their lives. pulmonary hypertension, think of dysynchrony in the electrical system. There's a lot, the list goes on and on about the underlying mechanisms of heart failure in these patients. But, at the end of the day, it is a clinical subjective diagnosis that the clinician, knowing the patient the best, makes at bedside, that this patient has worsening heart failure symptoms or not. And indeed, no matter how, you define heart failure, and in this case, ICD-9 diagnoses, you know that the admissions with heart failure in these patients is on the rise in the US. And we've all seen these patients on the wards kind of coming back recurrently. The European data shows us that heart failure is the most common cause of death among adults with congenital heart disease. And indeed, if you look at the second, or nearly the third cause of death, it's sudden death. There's almost always an underlying element of heart failure in these patients. So I would argue that almost the entire panel of these patients have had some form of heart failure to variable degrees as an underlying, if not the underlying mechanism for death. So now, what are the current available therapies for heart failure? And we're all familiar with the disease-modifying medications for the usual heart failure patients, and CRT, IV inotropes. But I'm not going to be talking about these therapies in this talk because of variable successes and, frankly, lack of robust data for these patients. And instead, I would like to focus on the advanced components of heart failure management in these patients with MCS and transplantation. So starting with MCS, this is data from the UNOS database looking at the utilization of VADs, ventricular assist devices, in patients without, in the rosy and red colors, compared to those with congenital heart disease in these smaller bars right here. So what you notice is that adults with congenital heart disease have had relatively a flat utilization of VADs across the years. Whereas as these VADs technology improved, there's been an uptake, substantial uptake in the utilization of VADs in these patients. So that's a huge discrepancy in the use of mechanical circulatory support among these patients. And if the obvious reason is anatomy. A lot of these patients have very challenging anatomies that may not necessarily be accommodating for a currently available VADs. And if you also look at those patients who were listed with a VAD or have been listed without a VAD and then underwent a VAD, for whatever reason, the VAD contributed to upgrade of their status on the transplant list in this rosy color again. You notice that the percentage of patients or controls who don't have congenital heart disease who've had an upgrade on their status on the list is substantially higher than those with congenital heart disease in the blue right here. And if you overlay the two graphs, you notice that this is probably primarily due to the utilization of VADs. So our patients with congenital heart disease are being listed sometimes, but they do not, most of the time at least, gain the benefit of VAD support, which extends life in non-congenital patients and allows them more time and also a higher status upgrade on the transplant list, which ultimately allows them a better chance of obtaining a heart transplant. So you can think of VADs as, actually they do disfavor the listing status for patients with congenital heart disease if you think of this as a zero-sum game in the transplant list. So what about transplantation? Well, you also have to look at most of the data, or almost the entire data that we have, comes from the old system of listing, where we had 3 tiers. But now we practice in the new status listing. So think of those patients who used to be 1A. They've been stratified now to 3 different statuses. It's a lot of details, but these patients generally are basically, machines. Those with invasive hemodynamic monitoring and those with intractable ventricular arrhythmias. So again, machines and VADs disfavor adults with congenital heart disease. And those in status 1B now, which is, the light at the end of the tunnel, you see those with stable VAD, but those with congenital heart disease now, by default, are listed at status 4, which I believe is actually an improvement compared to the prior system. And those in status 5 and 6 are basically 2+ organs or any other diseases. But now, as congenital heart disease is recognized as a qualifier for status 4 listing, you have to remember that those with VAD have 30 days of discretionary time that they can spend in status 3 that other patients, like congenital heart disease patients, do not have. And you have to also think anecdotally now, at least from our practice, that these changes did not really change the number of patients that we submit letters for exceptions to the UNOS committees to upgrade them on the status list. But there are zoning changes that also probably favorably impacted these patients. And if you think about it, the more patients you have on the list, the more benefit you've gained from this new UNOS system. And if you think about the larger centers that take care of a large number of ACHD patients and do list them, so generally these patients are now being offered a little bit more frequently with organs than before. At least that's been our observation. Well, let's just think about these patients when they get listed and what happens to them before they have a heart transplant. And indeed, again, from the old listing system, which is not really old, it's just recent, those in the solid lines are those with congenital heart disease, and the dotted lines are compared to those without congenital heart disease. And you notice that across the board, at least in status 1B and status 1A, adults with congenital heart disease have much higher rate of mortality or being delisted due to being too sick, which is another surrogate for death in these patients. And there's a lot of theories and speculations why this is the case. Some of it is probably we're listing these patients too late on the transplant list, and also there is less utilization of VADs, which we know that they do save life in patients who have worsening heart failure status without congenital heart disease. We also looked at some risk factors for death or delisting on the waiting list, and indeed we identified renal dysfunction and kind of some of the usual suspects, those who are listed while in the ICU or in the hospital, obviously at high risk of adverse outcomes, as well as those who are mechanically ventilated, but also patients who have liver disease, which we know is prevalent among patients with congenital heart disease. And this risk basically model persisted even when you look at status 1B and 2. So the way I think about it, there are patients with high-risk features who were listed at a lower priority status and had adverse outcomes on the transplant list, and probably they should have been listed at a higher listing status. So we do use these risk factors when we're making the case for UNOS to upgrade patients on the transplant list, and it does help our patients. What about after patients receive a transplant? Well, we know since the early 2000s that actually patients in the dotted line are those with congenital heart disease, and the solid line are those without congenital heart disease. That you notice that there is a drop in the survival in patients with congenital heart disease in the first year. So these patients do poorly in the first year post-transplant. But if you do a conditional analysis, meaning that you take all survivors at the 1-year mark and you evaluate them long-term, you notice that patients with congenital heart disease do substantially better than those without congenital heart disease. So we're going to talk a little bit about the why in a little bit. But think about it as this is an opportunity, sort of a high-risk, high-reward type of situation among these patients. And if you look at even the ISHLT publications and reporting, these are patients in the first year post-transplant, and the yellow, fittingly, it's the line that is most difficult to see. But essentially, these patients do relatively poorly in the first year. And if you notice, really the drop happens in the first month or two post-transplant. And the only population that does worse than this are those with retransplants. And if you look long-term, you notice the same graph where there's overlap and then an uptick of those with congenital heart disease. And if you do a conditional analysis on survival to the first year, indeed, congenital heart disease patients are the best patients long-term post-transplant. If you look at the causes of death in the relatively early phase, so this is analysis in the first 30 days post-transplant among those with congenital heart disease, you notice that compared to other diagnoses, there's a significant percentage of patients who died because of technical causes and those who had multiple organ failure. So the way I think about it is, there's something that happened in the operation or maybe before the operation in the planning phase for this surgery that contributed to the demise of these patients. And also there may be some other bystander organ disease that was not recognized, such as liver disease in these patients. But again, this data is speculative, and we do not have congenital heart disease diagnoses from these registries. So they lump them all in one category. But you do see a persistent pattern even when you look at other organs, such as heart and liver transplant, that the majority of patients who died in the first 30 days post-transplant among the congenital heart disease population died due to technical causes, have to do with the actual operation. So that's where actually opportunities lie for us to improve access and planning for the operation for these patients. So what about the positive end of the story where, why do they do better long term? Well, if you look at the age distribution, these are all patients, and patients with congenital heart disease are tagged in the color yellow. There's a lot more yellow in the age group of 18 to 39. So these patients are very young. So when they're young, they have a lot less comorbidities. And we do know that age matters. So these are all comers. And you see that there's nice stratification of risk in the UNOS database, that those who are the youngest accrue the best long-term survival compared to others in this registry. And it makes sense, all patients converge or relatively start at the same line. And as time passes by, that's when you see the comorbidities. That's when you see the reserve of these patients. And obviously, if you're younger, you have more reserve and you tolerate more insults or secondary complications of long-term immunosuppressant therapy and transplant. But kind of back at the not so positive end, which is why do they die earlier? Well, some people may think, okay, is it due to rejection? A lot of these patients have had a lot of operations, have been exposed to blood products and homografts that arguably could render them sensitized. But if you look at the rate of rejection treatment among those with congenital heart disease, it's not that much compared to other forms of heart failure patients who got transplanted. So really rejection does not, at least does not address the entire picture or does not tell you why these patients die early at such kind of striking rate. So the way I see it, there are multiple factors, and we're trying to tackle these factors one at a time. So I do think that a lot of these patients are listed too late. So those with the highest priority status, we know that they die way too frequently compared to non-congenital patients. And it has to do with our relatively lack of understanding of how sick these patients are. They really have a lot of reserve, so they may look okay until they don't. And that's when really it becomes hard for us to rescue them, especially when you don't have the benefit of mechanical support. But also you have to think of the technical approach at the time of surgery. Ischemia time. While the reported aggregate data or statistics from UNOS does not tell you that the ischemia time is substantially longer among these patients, I bet you if you look at individual patient groups or diagnoses, you will find that those with Fontan circulation, for example, or complex PA reconstructions do have longer ischemia time. But you have to think also about the unanticipated problems. The last thing you want as a surgeon going into this surgery is to find unanticipated issues. Seeing a stent lying in the PA where you want to make your anastomosis, we should know this stuff ahead of time. It may seem, a little bit, surprising, but to a large degree in our busy lives, that's what happens. You discuss the patient 3 months prior, and then they get a heart. So some sort of, you need a mechanism, really, an instantaneous mechanism to summarize the complexities and the multidisciplinary discussions that we have on these patients, so that when an organ becomes available, you can go back and review it and basically be well prepared. The sensitization is not, I mean, I think the jury's still out, and we have a grant that we are actually analyzing the data and preparing the manuscript to look at the sensitization for adults with congenital heart disease, and we have exciting data. It basically does not tell the full picture. But we also have to remember that there is under-recognized liver disease, especially among those with Fontan circulation. So, anecdotally, we see a lot of these patients that come out of the OR severely vasoplegic, irrespective of their liver status, but those who have kind of liver disease that is approaching advanced fibrosis struggle the most and require a lot of inotropes and pressors in the immediate postoperative period. The collateral burden is probably, really, really under-recognized, and it's an issue that maybe it's difficult for non-congenital providers to keep thinking about even post-transplant. But we see these patients have a lot of bleeding issues intra-op when they have a lot of burden of collaterals. We see this among patients with heart-lung transplant, where there's a lot of chest wall collaterals that lead to bleeding and contribute obviously to the ischemia time. But also long-term, many of these patients, especially those with the Fontan circulation post-transplant, will present to you, and it's remarkable how I see the right heart caths post-transplants when these patients come for their biopsies, and their cardiac output is 9 liters per minute, 10 liters per minute. You can't let these patients ride at this high output for a long period of time. So our approach has been to kind of, for ACHD, to see these patients at the 6-month and the 1-year mark to decide when to close the collaterals to preserve the graft function for these patients. We also really under-recognize genetic problems. How often do we order genetic testing on a patient that is undergoing transplant evaluation? And a lot of the genetic issues probably have a current of behavioral barriers that contribute to, these patients not taking their medications or have poor follow-up and so forth. But that's not a large proportion of these patients. But when you rephrase the question, you have to say, well, how can we mitigate these risks? And how do we address all these concerns so that we can push the envelope and get the rewards without accruing the risks for these patients? So our approach has been to have ACHD program and the multidisciplinary planning committee at the core of evaluation for these patients. So essentially, the way I think about it, you have a large heart failure program, and then you have a growing adult congenital program, and your institution starts getting referrals from everywhere for patients with congenital heart disease requiring transplant. Referring doc may not necessarily recognize where this patient lies throughout this paradigm of heart failure. So, our approach has been to have the ACHD program evaluate these patients with imaging, proper cardiac cath, discuss them in the multidisciplinary conference, where it is attended by one of the heart failure delegates, and it is attended by the transplant surgeon. And we decide as a group whether the patient, we need to basically put the transplant on hold and do cardiac repair or complex intervention, with the understanding that you will have advanced cardiac care support in case something happens to that patient, versus proceeding with heart transplant. And if we opt for heart transplant, we come up with a document that basically details the anatomical challenges and the anticipated issues at the time of transplant. And sometimes we do virtual VAD transplant for patients with complex chest wall anatomies, just to kind of get an idea how easy it is or not easy to implant ventricular assist devices. But, kind of having the privilege of being at a remarkable heart failure institute and a rapidly growing program, I have to think of we're two programs that are super busy in parallel sometimes, but we need more crosstalk amongst us. And if you think about a usual heart failure patient, non-congenital patient in the blue here, they have an event at whatever age, 50, 60, an MI maybe, or myocarditis. And that's when they start being symptomatic and go down the heart failure route. You have disease-modifying therapies that stabilize these patients for a long period of time. And we have very, very good metrics and triggers of when to refer these patients for advanced therapies. And indeed, during their listing, while they're listed, we have a lot of ways where we can mitigate their risks, whether it's VAD or inotropes or invasive hemodynamic monitoring. Whereas adults with congenital heart disease, I mean, they dance around this curve all the time. But, often it is due to, an acute arrhythmia in patients who had an underlying current of heart failure. But we're able to rescue them. We can do EP study, ablation, we can do a pacemaker. Maybe they have a usual suspect type of problem, like a myocarditis, or they have a surgical intervention where they linger a little bit, but then the rebound, but they almost never rebound back to where they started. So that's when we really, I believe we need our heart failure colleagues to be equally seeing these patients, because they will pick up on other issues that we commonly miss as the ACHD providers. So that's when we really have to collaborate at both subspecialties in caring for these patients, so that we do list them at an earlier stage, so that we do not accrue the risk at the time of transplant, when we think about these patients. We also have to think of the bystander organs. So we have a hepatologist as well in our meetings, especially for those with Fontan. And it's interesting that how the pendulum is swinging on those with Fontan, where when it started, people were doing a lot of heart liver, and now they sort of kind of dialed back. But now we're thinking of doing a little bit more heart livers, because it just makes it a lot easier to manage these patients in the immediate postoperative period, because they're not as vasoplegic. So with this in mind, let's go back to our complex 3 patients. So Michael, to remind you, he's the patient with a Fontan who had a severe cardiomyopathy and had a resuscitated sudden death. We actually put a VAD in him for 9 months before he got transplanted literally last week. And we know that he struggled with collaterals throughout this 9-month period after we implanted the VAD. We're actually writing up his case because we had to close collaterals at least twice throughout this 9-month period. It just, all the collaterals popped open and his aortic valves start opening, and his ventricular size increases. So it's just very interesting. We opted for heart transplant alone, so he came out of the OR very, very vasoplegic. Well, I mean, he did not have advanced liver fibrosis, but you can imagine, what a congested liver for your lifetime may do to you. And he required brief dialysis throughout this period, but now his kidney function has recovered. But that was his VAD, after we transplanted it. We did a virtual transplant before we proceeded. This is not very common that you have a pure cardiomyopathy presentation in a patient with Fontan. But when you see it, sometimes you just have to think slightly outside the box or back in the box of usual heart failure, of maybe these patients will do better with a VAD. And indeed, what's interesting for this patient is his Fontan pressure decreased after we implanted the VAD. So that's just a reflection of how increase in the EDP was contributing to the elevation in the Fontan pressure in this patient. So Nick, the patient with the D-loop TGA, who had a mustard and had a failing systemic right ventricle, he too underwent a VAD implant for 1 year. He was a very large guy and ultimately underwent transplant successfully. And I have to say that, kind of being in the OR with the surgeons, the amount of muscle that you have to clear out of that RV is substantial. But also you have to be careful because of the papillary muscles, and you do not want to compromise the tricuspid valve function. But he did extremely well. Geoff, who had tricuspid atresia and had a failing Fontan, severely reduced EF, and also advanced liver fibrosis. So that guy, we listed him for heart liver, and underwent successful transplant. I mean, it was remarkable, the kind of the contrast of perioperative management for these patients. It is really a little bit easier to manage them once they have a good liver. So they're not as vasoplegic, and you don't run the risk of hypotension and other organ dysfunction. He too had a lot of collaterals post-transplant. So at the 6-month mark, we cath him and closed a lot of aortopulmonary collaterals that were overloading his new graft. So in summary, I think of kind of a number of evolving strategies when we are addressing this problem in these patients. We really ought to develop a workflow to account for the complexity of these patients. And we always have to remember that there is a high reward potential, real potential for these patients. Really, if you think about the complexity, it's front-loaded. So if you do appropriate planning, perioperative, multidisciplinary, intraoperative planning, these patients do very well. It is resource intensive. So you really have to partner with administration. A lot of this work is not reimbursable. But you have to make the case that, unless you do this part, your surgery is not going to be as successful. You do need collaboration between ACHD and heart failure across the board for these patients. But we also don't know yet exactly which Fontan patients not to list them for dual organs. And we're still figuring that out. I think registry data will be very important from that regard. We also don't know at what level of restrictive lung disease we should consider heart-lung transplant in these patients. A lot of our patients have had multiple surgeries. They do have invariably some form of restrictive lung disease. But at what point do you say we need to consider heart-lung transplant? And we also have to remember that the role of mechanical support is increasing, but probably we're not going to have a measurable impact unless newer tailored devices are developed specifically for the variable anatomies of these patients. And lastly, there's striking, remarkable lack of data of heart failure in these patients before we even consider listing and transplant in these patients. We don't know the long-term risk factors for these patients as well as the usual heart failure patients. That's really where most of the work ought to be performed. And I would like to leave you with this kind of thought, which is fitting given the recent news about the 3 Nobel laureates. So on the left hand is Dr. Peebles. On the right hand, these two, Dr. Meyer and Dr. Quiellos. So these two discovered the first exoplanet, or planet outside the solar system. And that's why they were awarded with the Nobel Prize in Physics. And if you think about the habitable zone, that's the reward that we think about in physics these days, which is you really need to find a planet that is not too close to the sun because it would be too hot, and not too cold or far to sustain life. That's how I think about transplanting these patients. You really have to find the right time, the right team at the right institution to perform transplants in these patients, and you'll get the rewards. And I'd like to thank our entire team at UC San Diego that helped us catapult our program to where it is right now and for the future. And we're hiring more and more ACHD providers, I think, over the next few years, just to kind of meet the demands of the programs. Really, the superheroes are our coordinators who know the patients by heart. We go to the weddings of these patients, to their bar mitzvahs, to their births, and it's a remarkable journey taking care of this population. Thank you.
Well, great. Oh, my goodness. I don't even have to start with a question. Looks like there are already many questions. Dr. McGilvray.
Laith, first of all, congratulations on the fantastic program you've developed in San Diego, and also thank you for a terrific Grand Rounds. The concern about technical issues during transplants in these patients, I think many of them have to do with the bleeding that takes place from collaterals. Could you give us some insight into what the paradigm you use for managing these collaterals? I mean, what hierarchy do you go after? When do you start to go after them? How do you stage them?
To rephrase Tom's question, think of collaterals as an evolving process. It's not a static process. So I think if you think about it this way, I think it becomes easier to manage them. So those with Fontan have a lot of two types of collaterals: aortopulmonary collaterals that overload the ventricle. So those are not good. Those have to be closed. So we do once the patient is listed, we do a cath that is dedicated to close the entire collaterals. And if we think there's a large burden, then we stage it over two caths, not to give them too much contrast. So those have to be taken care of. We do revisit them every 6 months while they're on the transplant list. The veno-venous collaterals, which also tend to cause some bleeding as well, are a little bit tricky. If you think about the initial Mayo data about closing veno-venous collaterals in those with high Fontan pressure, that was a very small case series, and it hasn't been re-challenged in recent practice, meaning that maybe with diuretics you can offload these patients, pulmonary vasodilators, and you can be aggressive. So we try to close them as much as possible, unless the Fontan pressure is too prohibitive. With the understanding that, what's interesting about these veno-venous collaterals is they're reverse post-transplant. And they become really, really harder to close because you can't find them anymore. Talking to Jamil and others who've been doing this as well, we try to be very aggressive and close all of them. I mean, this patient is on the list. We're not looking at long-term survival for 5-10 years at this point. We're looking at improving the technical ability at the time of transplant.
Great talk, and thank you for visiting us. I'm on the receiving side for the transplant as a transplant program. And I think you very beautifully alluded certain conceptual frameworks, which I'm hoping that the adult congenital community will come up with. Objectively, the beautiful graph that you showed where there's spikes up and down for these patients, what we lack is the objectivization of mortality. So my question to you is, I can go to an outpatient Seattle heart failure model and quote a 1-year survival and use a competing risk and say, it's probably time to start talking about transplant or VAD. And if you think about it, it took decades for us to develop that in heart failure. It's just recently that we're able to recognize it. Do we have enough databases where you could compute a multivariate risk model for the outpatient setting? Because I think you don't want these patients to be hospitalized inpatient to get a transplant. And with that said, my second lead question is, when they're listed status 4, at least the good part about the current system is they have a higher status than status 6. Do you think anybody who's listed on status 4, if they get an offer, we should just take it? Because for status 6, we sometimes don't take a transplant because they're stable outpatient. And then, because you do have a competing risk for transplant, they're not going to live forever, right? So where is that balance, that earth? Can you give us tools to find that earth for us to transplant patients?
So 2 questions. So to answer the first question about risk factors for the stable outpatient, the short answer is no. We don't have a national registry of heart failure, even ACHD. I can tell you anecdotally, the way we do it is we have a heart failure and ACHD clinic once a month. So myself and a heart failure doc, we identify patients who are on moderate or higher doses of diuretics, any patient who's ever had any heart failure admission, if they have any systemic ventricular dysfunction, that triggers basically a referral to that clinic. And we establish with them and we collect data, and we don't know exactly. And at the end of the day, it's going to be a subjective or semi-subjective assessment by the ACHD provider who knows the patient the most. We do know that from cardiopulmonary exercise data that if there's a drop in the percent VO2 max, it does portend poor outcomes. But the data is not very clean, and I'm not sure if it's that predictive. Renal disease, liver disease are all also predictors, but we don't have robust heart failure Seattle models to calculate the risk for these patients. To answer the second question about the status 4 versus 6, if you have a 20-year-old kid, status 4, you don't want to give them a 50-year-old heart. I mean, there's no cutoffs that we use. So we do transplant a lot of Hep C positive, and we're figuring out whether to expand that to the Fontaine population or not, who are only listed for heart. There's early evidence of, vasculopathy in some of these patients with the Hep C positive donors. So we tend to kind of shy away from giving it to very young patients. But no, I don't think anybody nationally has kind of clear idea of what constitutes a suitable organ. When you see a very good organ, you know it's a very good organ. But anything in between, I don't think there's been a good matching.
My last question is about MCS. With their anatomical challenges, there are times we're trying to figure out LVAD versus RV support. Have you had experience using TAH as an upfront option of cardiac replacement in these individuals, and do you think that's a strategy that would be viable?
We have not. I think they've tried with TAH kind of a few years ago, and we have not done them in the recent past.
Yeah, again, thank you for a very stimulating presentation. My interest is in stroke occurring during advanced cardiovascular interventions, and in particular in the pediatric population. So most of the complications you listed, it said cardiovascular complications or cardiovascular death. Didn't really break it down into what those causes were. Can you talk a little bit about the incidence of stroke in a pediatric patient who gets an LVAD, and then project it forward into the adult patient with congenital heart disease? What's the background incidence of stroke in a variety of different circumstances?
So I'm not a pediatrician, but I can tell you, so to the audience, probably what you're implying is, anticoagulation in pediatric population is trickier than in the adult because the dosage adjustment is just different. We have not seen a higher incidence of strokes in at least the modern era VADs. Again, the data from UNIS is relatively, well, it is well before the newer devices became available. So there's no reason to think that the stroke incidence is not lower in these patients with the newer devices. I just think, if you have a patient who had a reconstructed arch, we were talking last night, like interrupted arch. Before we send them to any surgery, we have to look at the brain perfusion strategy. And then you would be able to mitigate the intraoperative risk of stroke. But long term, I just don't think that there is a higher incidence in these patients compared to others.
Laith, so good to have you back in Texas. It's a great presentation. Just looking at the data that you showed us, this is certainly not my specialty, but if you want to have a major impact in what you've done for transplantation is addressing the earlier complications. Because it looks like the survival, if you can make it within the first year, your survival is better than other populations with heart transplantation. So the question to you is, one, do you have a registry that looks at actually the more recent data with your awareness of all the things that could be done differently in this population compared to the others? Or can you mine the other data to delve into these technical quote-unquote complications, which could be, collaterals, et cetera, et cetera. So that's one, to give you maybe a feel of what you need to address. And two is, at least with your center and maybe other centers who are very aware of the comprehensiveness of what you do, et cetera, what does the early mortality nowadays, we're not looking at longer mortality, what does the early mortality look? Is it looking any different than the historical data? Is it better? Which at least would give hope to these patients and to the programs that you guys are initiating.
So great question. So I'll start with the second. Subjectively, we haven't looked at the actual data, but we do see a much better survival in these patients, at least in our experience, compared to the published data. Some of the data is telling because if you're a low volume center, you have a higher risk of mortality in these patients. I do know that there's efforts at adding variables that are congenital heart disease diagnoses to the ISHLT database, especially with the new listing systems. So I think that would give us a nationally representative data about that is more meaningful. But unfortunately, unless the large centers who transplant these patients combine their kind of detailed data sets together, we're not going to have meaningful results yet.
I would push in that direction because your population, just like also you've outlined it in your nice JAC paper and everything, this is a different population. And either you target it or you push for it in a way, because the way you approach it, the disease, the pathophysiology, the complications, everything else is different than you're transplanting an adult with ischemic or non-ischemic cardiomyopathy. And the issues are so different that you'll heighten the awareness of all the centers that are trying to do this kind of thing, right? And Billy, you have...
So I'm going to ask real quick. Thank you for a great talk in the back. So you mentioned collaterals and liver failure being two of the biggest issues and barriers to successful transplant. And you talked about how you address collaterals. I'm curious how you address liver failure and the best way you assess it. Does biopsy trump all other information, or if you have a biopsy that's stage 3, for example, you have concerning imaging or lab findings that make you hesitant to go forward without liver transplant concomitantly?
Yeah, so the way we think of liver and Fontan particularly is there's a transplant patient and there's a usual patient or long-term follow-up. For the transplant purposes, yes, we do non-invasive imaging. And if the fibrosis score is 3 or higher, then you definitely need to biopsy. And you have to get multiple biopsies, at least 5. We do it transjugularly unless the anatomy does not permit, then we do it via IR, percutaneously. If you find any degree of bridging fibrosis or advanced fibrosis, then we do list these patients for heart liver. We just do not, because you could only actually underdiagnose liver disease in these patients. It's a patchy process depending where you biopsy. So you have to take your highest grade of fibrosis and go by that. But there's no non-invasive, very accurate measure of fibrosis in these patients yet. Bridging fibrosis. We also look at, there's other criteria, like how big is the liver? If the liver mass is small, then, that patient is advanced fibrosis. I don't care about the biopsy. If there is, obviously, varices and the platelets are super low, there are other indicators of advanced liver disease, or the patient has other risk factors like drinking.
I think that historically, and if you look back at heart transplant for Fontan patients, it was awful, and it was a big, black, deadly hole that people were worried about trying to fill. And I think part of that has to do with the big, busy congenital heart disease programs weren't necessarily big transplant programs, and vice versa. Now, with programs like yours, the combination and the teamwork has really made a big impact on how these patients are doing and how they will do moving forward.
Did you want to say? Yeah.
Thank you, Laith, for a wonderful presentation and for your commitment to doing this for our patients. 2 questions for you. Number 1, we know that you mentioned that any systemic ventricular dysfunction will trigger consultation to transplant, but specifically for Fontan's, we know that preserved ejection fraction is not necessarily a marker of well-being. And a lot of times diastolic dysfunction of those single ventricles, especially those with hypoplastic left heart syndrome and chronically increased afterload, seems fetal life. So I was wondering if specifically for Fontan patients, we should look at other markers, Fontan pressures, and establish a different exercise capacity criteria, because we all know that they also do better than the usual patients that get referred for transplant in exercise stress testing. So, and this leads to referring them for transplant when they have advanced liver disease, recurrent ascites, protein losing enteropathy, malnutrition, all of which can worsen their outcomes long term. So should we work to set a different criteria for this very different population? And the second question is, you have started an ACHD transplant at a center that didn't do those before. And I am curious to know what was the learning curve for the support team, the ICU, and also the heart failure team at getting, you mentioned that now many things that had to be discussed very carefully now are automatic. So I'm interested in knowing about that.
So to answer the first question about the other unusual risk factors that we could utilize in the Fontan patient to support your case for listing. So actually, if you read through the recent criteria for UNOS, they do designate protein-losing enteropathy as a risk factor for death, and you can use that as an exception, and we have used it. And we know almost 95% or more of patients with protein-losing enteropathy, it goes away within 3 months after transplant. So it does have to do with the failing Fontan circulation. So high pressure equals cyanosis. So cyanosis is another criteria for exception. So there's a lot of ways you can make your case, whereas maybe the VO2 is 20, but the patient's saturation is 70. And Fontan pressure is 20, you can't close these collaterals. So you cannot mitigate cyanosis. That's actually in and of itself a criteria for exception. And you can list them sometimes to status 3. To answer the second question about kind of teamwork and education and how do you kind of add another stream to the large river without disturbing flooding. That's what I was looking for. Honestly, you have to think as a small team. You can't start big. You have to think small. Providers have to talk to each other. So we round on the patients together. You have to make time from our busy schedules to go accommodate the heart failure rounding schedule. For the ICU part, for me, it was the silver lining was that the institution does substantial CTEPH surgery cases every year, and so they know how to take care of sick RVs. So for me, I use that as a springboard to help them kind of navigate the Fontan physiology. And it was actually a smoother transition than I expected, if you think about it this way. So we have nurse educators as well for the nurses to talk to them about Fontan and so forth within the ACH and, IV management and things like that. And we have lecture series for the anesthesiologists who are very fascinated by these patients and have done a phenomenal job taking care of them. So, we can't do it alone. That's just, at the end of the day, and this is a confession, we think we're special as ACHD specialists. Nobody is special above and beyond of the help that you're providing for your patient. So it's a teamwork, and kind of crossing the barriers is the key when you take care of these patients, just like what you guys are already doing here. So.
Thanks, Lee.